A warm welcome to everyone in the anesthesia class. The topic that we are going to study today is central neuraxial block, which is an extremely important topic on the point of view of the NEET-PG. Around expected are like 30% of the part of the anesthesia could come from the CNBs. See, central neuraxial block is a type of regional block that leads to reversible, please remember this word, reversible loss of autonomic, sensory and motor sensation when we provide the local anesthesia to a particular area of the body, right? It could be like topical, infiltration, bias block, central neuraxial block or peripheral nerve block. When we talk about specifically about the central neuraxial block, it is nothing but the block of the spinal nerves. That is your central nervous system, which is your brain and your spinal cord. So now we are going to block your spinal nerve roots. This is the target of the CNB block. Please remember this. The target of the CNB block is to block the spinal nerve roots. Before we proceed towards the central neuraxial block, let's have a recapitulation, a very short recapitulation of the anatomy of the vertebral columns. See, the vertebral column consists of 33 vertebra. Our spinal cord is not straight. We have thoracic lordosis and sacral also is lordotic, whereas the cervical and the lumbar, they are kyphotic. We have 7 cervical, 12 thoracic, 5 lumbar, sacrum of 5 but fused together, and coccyx 4. You have to remember the numbers of the respective vertebrae. We have 31 pairs of spinal nerves that are coming out. Please remember that all the spinal nerves are going to leave the vertebra one level lower. It is never from the upper border. It is always from the lower border that your spinal nerve is going to leave that respective vertebra, except the cervical nerve. The first cervical nerve is the exception, which will go upwards and not go downwards. That is the only exception. Spinal cord, nothing but it runs through the spinal canal. It is formed by, when we stack the vertebra together, a hollow passage is formed. Through that hollow passage from the base of the skull to the sacrum runs our spinal cord. The contents of the spinal canal are, we have a spinal cord, then we have certain coverings of the spinal cord which are known as the meningeal layer. Then of course we have a fatty tissue, we have blood supply to the spinal cord, which is the arterial blood supply, and the venous, which is known as the Bateson's plexus. And lastly, we have the terminal branches from the spinal cord, which are your dorsal and the ventral nerve roots, which are then going to join to form your spinal nerve roots. The extension of the spinal cord is extremely important and asked a lot many times, because this is very relevant, where actually we have to give a spinal or epidural anesthesia, because we have to protect the spinal cord, specifically spinal anesthesia. Extension of spinal cord in adults is lower border of L1. Lower border of L1, whereas in children it ends up at L3 upper border. I repeat, in children it is still the upper border of L3, whereas in adults it is still lower border of L1. In adults it is lower border of L1, and in children it is lower border of L3. Okay. When we talk about the dural sac, this is the dural sac. The dural sac in adults extend up to S1 to S2, whereas in pediatric cases it extends up to S3. I hope this is clear to you. In adults, the spinal cord is still the lower border of L1, and in children, it is the upper border of L3. Okay, because it is always safe to give spinal anesthesia below these levels in adults and children. And this is what is asked, uh, which is the safest area in which spinal anesthesia can be given in pediatric cases. And options are given, and you have to choose the option which is below the L3 level, that is mostly L4, L5 is in the options, right? And it takes around 3 to 4 years for the children to come back into the adult vertebrae or the adult extension of the spinal cord. This is your spinal cord, the cervical, thoracic, lumbar, sacral, and the coccyx. We have three parts of spinal cord whose understanding has to be there in your minds. One is the conus medullaris. Conus medullaris is nothing but the terminal part of the spinal cord. This is nothing but the terminal part of the spinal cord, which is this bulge or the elongation. Okay, and this ends at your L1 level in adults. I told you this ends at the L1 level of the adults. But still you have your lumbar spinal nerves, your sacral spinal nerves which have to come out. All these nerves will be coming out, descending out a little lower in the form of a horseshoe tail, which is known as the quadra equina. Is that clear? What is quadra equina actually? It is nothing but the lumbar and the sacral nerves which transfers a little downwards and come off after coming out of the intervertebral foramen and form a horse tail like appearance known as the quadra equina. This is the quadra equina. Your spinal cord has finished, but still you have your vertebral column which is present. Your spinal nerves are going to come down from the spinal cord in the form of a horseshoe tail, which is known as your quadra equina. Right? Quadra equina, lumbar and sacral nerves are there. Then phylum terminal. Phylum terminal is nothing but a thick fibrous tissue. This is that tissue which joins the conus medullaris and attaches to the first coccyx vertebra. And this is formed by nothing, your pia mater. Phylum terminal is nothing but a fibrous layer which is formed by the pia mater, which joins from this conus medullaris till your first coccyx vertebra. Is that clear? Conus medullaris, quadra equina, and phylum terminal. These are the three parts which are separately asked. Phylum terminal, nothing but extension of pia mater, which terminally attaches the spinal cord, that is the conus medullaris, to the periosteum of your coccyx vertebrae. Now this is your target. Finally, you have this is the cross section of the spinal cord. You have the gray matter inside and white matter outside. This is the dorsal nerve root. This is the ventral nerve root. This is the dorsal ganglia. This is the dorsal ganglia. This is the dorsal nerve root. These are the ventral nerve roots, and they both join to form a common spinal nerve root, which we actually block. Now talking about these two nerve roots, there are the different sensations which are being carried by the dorsal nerve roots and your ventral nerve roots. When we talk about the dorsal nerve root, it is actually responsible for all these somatic and visceral sensations. Please remember, all the somatic and visceral sensations are carried by the dorsal nerve root, whereas the ventral nerve root is responsible for the motor sensation, and along with the ventral nerve root we also have accompanying the autonomic nervous system, that are the sympathetic and the parasympathetic nerve roots. Thus, ventral nerve root, we have motor sensations and autonomic sensations also, because your sympathetic and parasympathetic are also arising just near your ventral nerve roots, and they travel along with the ventral nerve roots. I hope this is very clear. Dorsal nerve roots are responsible for somatic and visceral sensations, that are your sensory, okay? And motor sensations and autonomic sensations are carried by the ventral nerve root. This is the cross section of the spinal nerve. This I've already told. I'm not going into detail of the tracts. CNS, we block the roots. Dorsal, the dorsal means posterior. It is sensory, whereas ventral, I'm sorry, it's wrongly written. Whereas the ventral, it is motor and your autonomic informations. Now the blood supply of the spinal cord. Remember just one thing. We have anterior spinal artery. We have posterior spinal artery. Majorly, it is the anterior spinal artery which is going to supply 2/3 of the spinal cord. The whole ventral part, almost 2/3 is supplied by the anterior spinal artery, and it is only single. As you can see in the diagram, there is only one anterior spinal artery, right? But when we see the posterior spinal artery, we have two posterior spinal artery which are responsible for giving blood to 1/3 of your spinal cord. The anterior spinal artery is a branch of the vertebral artery, whereas your posterior spinal artery is the branch of posterior inferior cerebellar artery. This is the branch of posterior inferior cerebellar artery supplying 1/3, whereas anterior spinal artery will supply your 2/3 part of your vertebral spinal cord. There is one more artery that is present, which is known as the artery of Adam-Quich, which is asked also. This is arteria reticularis anterior magna. What is this artery is? This artery arises directly from the aorta. It is unilateral, present on the left side only, and it is present only for a limited part of your spinal cord, from T8 to L2. That's it. But it is going to provide a major blood supply to this anterior part of the lower 2/3 of the spinal cord. I repeat, this artery is only present in the thorax and lumbar T8 to L2, but at that level, it forms a major chunk of the blood supply of the anterior part of the spinal cord. That is along with your anterior spinal artery, but only present for T8 to L2, that too only on the left side. I hope this is clear. Please revise it again so that you're able to remember the blood supply. One anterior, two posterior, and one exception artery of Adam-Quich. Now, a very brief thing about the lesions of the spinal cord, because once only they were asked in the previous year questions from anesthesia. Yes, they are very important on the point of view of medicine. We have three syndromes. Central cord syndrome. This is the area which goes in the central cord syndrome. Anterior cord syndrome, because of the blockage of the anterior spinal artery. I already told you we just have one anterior spinal artery. And then we have Brown-Séquard syndrome. The anterior cord syndrome, as the ventral columns, when the ventral columns go, I told you that the ventral columns are responsible for your motor and autonomic sensations. There is complete loss of motor, pain and temperature, but still the vibration and the proprioception, which are carried by the dorsal columns, they are preserved. In the central cord syndrome, we have sensory and the motor deficit, but more on the upper limb, because that is the area of the spinal cord where we have the nerves that are supplying your upper limb more than your lower limbs. And in Brown-Séquard syndrome, it is, I told you already, it is present generally ipsilaterally. Okay, Brown-Séquard syndrome is ipsilateral loss. As you can see, only one side Only one side of the spinal cord is lost in this. So we have the ipsilateral loss of your motor, vibratory sensations and proprioception, whereas those tracts that cross, that are your spinothalamic tracts that cross, so you have the contralateral loss of pain and temperature. I repeat just once again, in the anterior cord, as you can see, in the anterior cord syndrome, we have the loss of the ventral columns. Thus, your motor, pain, temperature goes, whereas your dorsal columns, which supply for the vibration and the proprioception, they are preserved. In the central cord syndrome, that this is that area which supplies your upper limbs. So your upper limbs go more than your lower limbs. Both sensory and motor deficit can be seen. Whereas in Brown-Séquard syndrome, only a part of the spinal cord, half of the spinal cord goes, because of which the ipsilateral loss is there of motor, whereas the pain and the temperature we have contralateral loss because those tracts cross. Coming to cerebral spinal fluid. In cerebral spinal fluid, you have to remember two things. One, it is the ultrafiltrate of blood. Please remember, CSF is the ultrafiltrate of blood and it provides a cushioning effect to the brain and the spinal cord. Okay. And how is the cerebral spinal fluid produced and how it flows is very important. It is produced in the lateral ventricles through the choroid plexus. Done. From the lateral ventricle, then it moves to your third ventricle via foramen of Monro. This is your lateral ventricle. This is your third ventricle and this is the foramen of Monro. From the third ventricle, then it is going to go to the fourth ventricle through this cerebral aqueduct. This is your third ventricle. This is your fourth ventricle. It is going to go through the cerebral aqueduct and finally through the foramen of Lashka and Magendie. It is going to leave the fourth ventricle and go to your central canal. That is your spinal canal, and it also gets absorbed in the brain through the arachnoid granulation. And where in the spinal canal it is present? It is present around the spinal canal, giving the cushioning effect in the subarachnoid space. If it is asked where is the CSF present, CSF is present in the subarachnoid space. Okay, I hope the flow of CSF is clear. The density of the CSF is important because of a local anesthetics density. It is decided, the baricity of a local anesthetics is decided depending upon how much denser they are in respect to CSF, whether they are less, same or more. So density of CSF is 1.003 to 1.008 at 37 degrees Celsius. I hope that is clear. Moving forwards to the regional blocks. Why regional blocks are so important over general anesthesia? See, first, it is cost effective. Patient satisfaction is more. You can provide analgesia to the patient even after the operation. You protect the reflexes. There is no airway manipulation. You don't have to take away those protective airway reflexes of the patient. The bleeding is comparatively less in spinal anesthesia or regional blocks in comparison to general anesthesia. The incidence of embolism, deep vein thrombosis is also lesser post-operative nausea, vomiting, and yes, lower incidence of cognitive impairment because minimal amount of anesthetic drugs have been used. But there are certain disadvantages of regional block also. First, it can lead to hypertension. Then we have certain thing which is known as posterior punctured headache. We'll be coming to that later, which is a complication of your spinal anesthesia. Technically, it could be a bit difficult. Then we have urinary retention. infection which could be life hazardous like meningitis and encephalitis can happen after the spinal or the epidural anesthesia. And then of course we can have a problem of failed spinal, and you have to convert your regional anesthesia to general anesthesia. But when we talk about the regional blocks, they are very, very useful, because the very first thing that makes them useful is that there is no airway manipulation and all our protective airway reflexes are preserved. Mechanism of action. I've already told you about the dorsal nerve roots and the ventral nerve roots. Just you have to know what are dermatomes. Dermatome is an area, a cutaneous area supplied by a single spinal nerve root. That is your dermatome. Like for example, if we take our hands, the hand is supplied, one part of the hand is supplied by C8, the middle part. This is supplied by the ulnar nerve, which is the C8. So C8 is one single spinal nerve that is giving a sensation to a particular area, which is known as the dermatome. So when we say let's block till T4 level, it means you have to block till the dermatome T4. So dermatome is cutaneous area supplied by a single spinal nerve root. Done. That is your dermatome. We have already studied this in our local anesthesia class. It is just a recapitulation because it's important when we talk about spinal anesthesia. We have a differential block which is present here also, that are the most sensitive fibers, if you remember, are your preganglionic sympathetic fibers, that are your B fibers. They are most sensitive to your local anesthetics, followed by C fibers, followed by A delta, A beta, and eventually your thickest of all, your motor fibers, that are your A alpha fibers. Okay, so the most sensitive are your preganglionic sympathetic fiber. So the very first sensation that is lost is your autonomic sensation, followed by your temperature, that is the cold and the hot temperature, pain, touch, pressure, and eventually your motor, and lastly your proprioception goes. Is that clear? The significance in spinal anesthesia is, suppose you have given the spinal anesthesia at one level, for example, you have given it at L2 level, the sensory loss, suppose the sensory loss is still L2 level, the autonomic loss will be 2 segments higher than the sensory loss. 2 segments higher will be the autonomic loss, whereas 2 segments lower would be your motor loss. Please remember this. Okay. If it is said in the question that the sensory level is TL2, so autonomic level will be 2 steps higher and motor block will be 2 steps lower than your sensory block. When we are giving the spinal anesthesia, we have to know about certain surface landmarks on the back. The landmarks are the C7, which is the vertebral prominence. The vertebral prominence is C7. Then you have the spine of the scapula at T3. Then the angle of the scapula, which is very important, T7. Then the iliac crest. We have the intercrestal line or the Tuffier's line. Extremely important to know. The Tuffier's line, that is the two highest point on the iliac crest. The highest point on the iliac crest, they are joined, and this line is going to go through the body of the L4. This is the surface landmark in helping us find the place where we have to insert our needle. Body of L4, or if it is an intervertebral space, it will be L4, L5 intervertebral space through the Tuffier's line, which is the highest point of the iliac crest. That lastly, we have PSIS, that are your posterior superior iliac spine at the level of S2. This is important when we will talk about the caudal anesthesia. I hope this is clear to all. Now we have two main types of central neuraxial block, spinal and epidural, and a lot questions are asked in the differences between the spinal and the epidural anesthesia. See, before we go to the spinal and the epidural anesthesia differences, let's see where the drugs are actually deposited. Then it will be very easy for you to relate to the same. See, this is your cross section of the spinal cord, and now we are going to do the layers which are pierced by the spinal or the epidural needle to reach their target. The first layer would be your skin and the subcutaneous tissue. Then you have your supraspinous ligament, the interspinous ligament. This is your interspinous ligament, followed by one of the toughest layers, which when pierced gives a gritty sensation, that is your ligamentum flavum. This is the layer which has to be pierced, and just after piercing your ligamentum flavum comes your epidural space. This is your ligamentum flavum. When you pierce your ligamentum flavum, we come to the epidural space, and this is where the epidural drug, the local anesthetics which are for the epidural anesthesia, are deposited in the epidural space. After the epidural space starts our meningeal layers, durameter, arachnoid meter and pia meter, and between the arachnoid meter and pia meter is our subarachnoid space, where you deposit your drug for your spinal anesthesia. And here you have the CSF. In the CSF you have your nerves which are floating, and you eventually block those nerves directly by giving your LA into the CSF. Is that clear? Now you see there is one more space here, that is the subdural space between the durameter. It is below the durameter. Okay, subdural. This is the space in which CSF flow may be present, but the effect of the spinal anesthesia will always be partial. By chance, the drug gets deposited in the subdural space. Is that clear? So we have two areas: epidural space between your ligamentum flavum and your durameter. You deposit your drug here. The problem with this drug is that a large amount of drug has to be given in the epidural space, because eventually this drug is going to act on your spinal nerve roots only. It is going to percolate slowly and slowly into your CSF by blocking the spinal nerve roots. So a large volume of drug is used, and the onset will be very slow because it will take time for the drug to percolate from the epidural space to the spinal nerve roots. But eventually what is helpful for us is that because of the fact that slowly things are happening, so all the systemic effects, all the hemodynamic changes which were very fast with the spinal anesthesia will be a bit slower and graded when we use your epidural anesthesia. I hope this thing is very clear. Next very important thing is that epidural space is a negative space. Always remember, epidural is a negative space. It's like a vacuum. And when we enter the negative space of epidural anesthesia, we have a loss of resistance, which is used to identify that space. Epidural space is a negative space. And it is said, edge over the others, it is said that this negative space is because of its continuation with our negative pleural cavity. That is why epidural space is said to be a negative space, and this is used in the recognition of the epidural space before we deposit drug here. I hope the layers pierced by spinal needle or the epidural needle is very clear, because this is asked, this is extremely important. Now coming back to differences. See, spinal anesthesia is generally given, I told you, after the finishing of the spinal cord, preferably. But when we talk about the epidural anesthesia, it can be given at every level. People give it at cervical level, at thoracic level, lumbar level, because you don't have to pierce the dura mater. You're not going to go near the spinal cord, right? The injection is in the subarachnoid space, wherein the injection is in the epidural space, which is between the ligamentum flavum and the dura mater. Done? Identification, the CSF flows. When you put the spinal needle inside, the CSF going to flow, whereas the epidural anesthesia, we have the loss of resistance. I told you it's a negative space. The drug that is required in spinal anesthesia is lesser dose of the drug or less volume of the drug is required, whereas in epidural, a large amount of drug is required. The onset of spinal is going to be very fast. It is acting directly on the nerve roots, whereas spinal it is slow because it will take time for the drug to percolate into the spinal nerve roots. The block density is very high when we talk about spinal anesthesia, whereas in epidural anesthesia it is less dense. And generally what happens in epidural anesthesia is we have sacral sparing also. We can have sacral sparing when we talk about epidural anesthesia. Okay, the hypotension, the hemodynamic changes are very rapid in spinal anesthesia, whereas in the epidural anesthesia they are quite slow. And when we talk about the most important, one of the most important complications of spinal anesthesia is your post-dural puncture headache. As the name suggests, because you have pierced the dura mater and thus the patient will be having your headache. Whereas in the epidural, you're not puncturing the dura mater, so the chances of headache decreases a lot. I hope the differences between the spinal and the epidural are clear. Let's move further. Now, how are you going to pierce it? Of course, you have to use your spinal needles or epidural needles in order to pierce these layers. See, when we talk about the spinal needles, these are the spinal needles. They come as an image-based questions. This is your spinal needles, and we have different kinds of spinal needles which are present. See, the spinal needle, what are the parts of spinal needle? We have a spinal needle inside which we have a stellate. A close fitting stellate is present inside the spinal needle, and always when you are introducing the spinal needle, it has to be along with the stellate in order to prevent the skin and the subcutaneous tissue from plugging the needle during insertion. I repeat, it is asked whether stellate has to be there or removed. You have to always introduce the needle along with the stellate inside it. Is that clear? The length of the spinal needle is around 9 centimeter. We have a tip of the spinal needle. We have a bevel. This is the bevel. This is the tip. We have a side hole in the spinal needle. Then we have a lever lock at the end of the spinal needle, which is opened, which is actually responsible for keeping the spinal needle and the stellate closely fitted together to each other. That's the lever lock. Lever lock. When we talk about spinal needles, they are generally of two kinds. One is the dura cutting needles and one is the dura separating needles. Is that clear? Cutting needles, as the name suggests, cutting, they are going to cut the dura mater, thus they are more traumatic. They are sharp in their tips, they are more traumatic, but the chances of successful spinal anesthesia is always better in cutting needles because of the feel that they give when we cross the dura mater. So I repeat, the cutting needles are more traumatic, but the chances of failure are lesser in comparison to the dura separating needles. The dura separating needles are, they are going to separate the dura mater, and when they come out, the dura mater is going to get closed. Whereas in cutting needle, it is going to cut the dura mater and go and thus we can have inflammation in that area, which makes it more traumatic. Now, what are the examples of cutting and separating needles? When we talk about cutting needles, we have quinky. This is the quinky. It has a very sharp tip with a bevel and a end opening. Can you see this opening? This is the end opening. This is the bevel and this is end opening. This is the cutting. The other example of cutting needle is Pitkin needle. Quinky babcock needle is the most commonly used needle in practice. It is of different gauges starting from 20, 22, then you have 23, you have 25, 26, 27, and these days even 28, which is the less diameter needle. As the gauge of the needle is going to increase, the diameter of the needle is going to decrease. It is vice versa. That is 24 gauge needle will have wider diameter than 27 gauge needle. This is more fine. 27 gauge needle is finer. Okay, it is an inverse relation. Talking about the dura separating, you have Vitacre, Sprouty and Greeny. These are the three dura separating needles. Okay, the Vitacre, Sprouty, they have blunt tips, or you can have pencil point tips. These are blunt tips they have, and generally they have side injections. These are the side injection ports. They're, if you see the tips, these tips don't have any injectable ports. They are side injections. The examples are very important. I repeat the examples. Cutting needles, they are more traumatic and there are higher chances of PDPH which are present in cutting needles. I repeat, the cutting needles, more traumatic and higher chances of PDPH. Whereas they are Quinky Babcock and Pitkin. Whereas in separating needles, you have less traumatic and lesser chances of PDPH. They are Vitacre, Sprouty and Greeny needles. These are your needles. Now, when we come to spinal anesthesia, what is the procedure? Now we have the equipment that is ready, which have the spinal needle, and of course we have already studied about the local anesthetic drug which is needed. So now comes the position. When we talk about the spinal anesthesia, actually the success of spinal anesthesia is dependent upon how are you going to position the patient. Now, three positions can be used. Why are these positions used? These positions are basically used in order to have the best possible interspinous spaces such that they open and we are able to deposit the drug into the CSF. These are done to avoid the rotation of the spine. That is why I told you that positions are very, very important, because if the spine gets rotated, if the patient is sitting like this or like this, then we won't be able to have the clear judgment of the space, that is the intervertebral space cannot be recognized clearly. Okay, and that can lead to failure or multiple attempts of spinal anesthesia. Thus, we have to open up the spaces between your spinal processes. The two spinal processes, between them we have to go. So to open it, we have to position it. Is that clear? We have three main positions. Three main positions. Sitting position, lateral decubitus position, and last prone or jackknife position. Last is prone or jackknife position. There are three positions which are present. I'll just show you the positions first. They are the three positions: lateral decubitus, the sitting, and the prone position, that is your jackknife position. Is that clear? I already told you about the dependent part of the spinal cord. If you remember, it is T5 to T7. When you are supine, after the position, after we give spinal anesthesia, of course, we are going to make the patient go supine. So dependent part of the spinal cord, where most of the local anesthetic is going to get deposited, is your from T5 to T7. See, how are these positions very, very important for us? First, these positions are important because of the comfort of the patient. For example, in an obese patient, in a pregnant patient, where there's a lot of fat in the subcutaneous tissue at the back, it becomes very difficult to find the intervertebral space. In those cases, sitting position is majorly preferred. Okay. Whereas if the patient has some fracture of the lower limb and the patient cannot sit, so maybe the patient prefers to be in the lateral decubitus position with the fractured limb on the upper side, on the non-dependent side. Whereas the prone position, if we talk about, it is used very, very less, and generally prone position is used only in those cases in which surgery is also meant to be done in that position only, like your fistulas, etc. Okay, so this is the least preferred position. Generally, lateral decubitus and sitting position are used. Now, the second importance. There is one kind of block known as the saddle block, which is nothing but spinal anesthesia. But after giving spinal anesthesia at a very lower level, L4 to L5 or L5S1, after that, the patient is allowed to sit for 8 minutes such that your drug is going to settle via gravity to the lower areas only, that are in saddle block. We are going to target only sacral plexus S2, S3, S4, that are generally the perineal surgeries, which are done. In that case, sitting position becomes extremely important because this is the only position in which we can get your saddle block, And the drug to be used is hyperbaric drug. The baricity of the drug has to be more than the CSF, only then it is going to settle down via gravity. Okay. In lateral decubitus position also, generally we give hyperbaric drugs, whereas in prone positions we give hypobaric drugs or isobaric drugs. Now, before we go further, let me recapitulate. This has already been done in LA classes, but again, I'll repeat it. Depending upon the baricity of the drugs, which is dependent upon the CSF density. The drug which is more than denser than CSF is hyperbaric. And as the name suggests, hyper, these drugs are going to settle caudal. Along with gravity, they are going to settle down. Okay, that are your hyperbaric drugs, which are made hyperbaric by the addition of dextrose. Percentage of dextrose has to be remembered. In bupivacaine, we have 8% dextrose, whereas in lignocaine, we have 7.5% dextrose. Lignocaine is not used these days for spinal anesthesia because of the neurotoxicity or quadri-Koina syndrome, transient neurological symptoms that it caused. So generally, we are using heavy bupivacaine or the enantiomers of the bupivacaine. They have 8% dextrose in them. They are hyperbaric. Whereas the hypobaric means, iso means same density. So they are going to settle at the same level where we have given it. Whereas hypobaric means they are less denser than the CSF, which are generally made less denser by the addition of distilled water and fentanyl. I repeat, hypobaric drugs are made less denser by addition of distilled water and fentanyl. And they are going to settle at higher levels against the gravity. Is that clear? Hypobaric are going to settle against gravity, hyperbaric along with gravity, isobaric at the same levels. These are the three positions: lateral, sitting, jackknife. Approaches. When we are giving spinal anesthesia, the very first step is position. Second step comes cleaning. You have to clean the patient and everything has to be done under aseptic condition. Please use your 2% chlorhexidine or betadine solution. Leave it for its contact time and then apply spirit, let it dry, and then only after full cleaning and draping, kindly introduce your spinal needle into the subarachnoid space, because your spinal or epidural can lead to a life-threatening condition of meningitis and encephalitis. And the interesting part here is that most of the commensals which were seen in this meningitis and encephalitis are nothing but your skin commensals which enter the spinal canal via your spinal needles. Okay, so be very careful. There can be two approaches. One is the midline approach, in which we introduce the needle midline, and other approach is around 1.5 to 2 centimeter lateral, that is your paramedian approach. The only thing that you all have to remember in these approaches is that when we talk about midline and the paramedian, in paramedian approach, there is only one ligament that comes. Your supraspinous, your interspinous, they both ligaments are surpassed. Only ligamentum flavum comes. Ligamentum flavum is the only common ligament between these two approaches. Paramedian do not have supraspinous and interspinous ligaments, because of which this is preferred if someone has a calcified ligaments like old age or in obesity or in scoliosis where the positioning becomes very difficult. In those cases, paramedian approach is preferred because the only common ligament is ligamentum flavum. In paramedian approach, there is no supraspinous or interspinous ligaments which are present. Okay. The procedure I've already told you. The tertius line, the highest point on the iliac crest, is joined. The way it is joined, the area where it is joined is generally the L4 body from which you start counting. If it is the space, it is L4, L5 space. Okay. Once you have deposited under all aseptic conditions your drug into the subarachnoid space, then you have to check the level. You have to check the level of the spinal anesthesia, which is checked by your sensory sensations are checked by two. One, temperature, that is your swab, spirit swab. It is very cold if you put it, that cold sensation will go away. And second is your pinprick. This is to check which is the highest dermatome that is achieved. Second is your motor. Your motor is checked via a scale known as the Bromage scale. I hope these two things are very clear to all. We have a sensory and a motor. Sensory check is done via your swab, that is your spirit swab, whereas pinprick sensation is checked for checking the dermatome level, the highest level. Second, motor checked by Bromage scale. Clear? Then we have a test dose. Test dose is generally used in epidural anesthesia. In epidural anesthesia, once we have given the, we have inserted the needle inside the epidural space, then what we do is we insert a catheter also. Sometimes a catheter is also inserted, which is very important if you have to give a prolonged duration of surgery. That this is one thing which I've forgotten. In epidural anesthesia, added advantage it gives a prolonged duration of surgery. That is an added advantage of it. But before we give such a large amount of dose in the epidural anesthesia, we give a test dose, which is nothing but 3 ml of 1% lignocaine with 5 microgram per ml of 1:2 lakh epinephrine. This is very important. You give 15 micrograms of epinephrine with 3 ml of 1.5% lignocaine into that catheter. Why do you give it? This is to test whether the catheter by chance has not gone intravascular or intrathecal. Intrathecal means into the subarachnoid space and intravascular into the blood vessels. If the catheter goes intrathecally, then we'll have the loss of sensation in the great toe. Loss of sensation in great toe and we have to stop there itself because our catheter has gone subarachnoid. And I've already told you the dose that is required in the spinal anesthesia, just 2 to 3 mLs, whereas you are going to give 15 to 20 mLs in epidural anesthesia. And just imagine giving 15 to 20 mLs in spinal anesthesia. Done. Intravenous is not, because it can lead to local anesthetic systemic toxicity if you give 15 ml of drug of local anesthetics into your blood circulation directly. So intravenous, how it is detected, that if epinephrine goes into intravenous, then you can see changes in the heart rate and the blood pressure. Both are going to increase on your monitor. Thus, intravenous and intrathecal epidural catheter has to be ruled out before you give anything else, any drug or spinal anesthesia after epidural anesthesia, to rule out intrathecal and intravenous placement of the epidural catheter. I hope this is very clear. Then we can have combined spinal epidural. Sometimes what is done is, if the surgery is of longer duration, we give a combined technique, generally needle to needle, needle through needle technique. First, we introduce the epidural needle till the epidural space. Then the spinal needle is introduced via that epidural needle into the subarachnoid space. After we inject the spinal drug, we very rapidly insert the catheter and then we let the surgery start. This is a combined spinal epidural anesthesia technique, in which the advantage is we get a dense block of spinal and we get an added advantage of the duration of the surgery can be prolonged via that epidural catheter, in which we can give a continuous supply of local anesthetics. Done. Secondly, one of the most other concept which you all have to remember is that generally local anesthetics that we are going to use intrathecally and in the epidural are preservative free. Please remember this. LA to be used have to be preservative free. Okay, we have only dextrose that is added to your hyperbaric bupivacaine. Whereas for that 2% lignocaine, which you all must have seen you use for local infiltrations a lot, it has methyl paraben in it. You don't have to use that local anesthetic to be given in the intrathecal space. It is only preservative free LA. If the options are given that which local anesthetic can be inserted intrathecally, please look for options which state something which is preservative free. If you all remember, the shortest acting local anesthetic, that was your chloroprocaine. Why the chloroprocaine was taken out from the market? The main reason for withdrawing the chloroprocaine was the addition of sodium metabisulfite in it, which was a preservative, which led to toxicity. It led to neurotoxicity, causing the quadra equina syndrome. That is why now chloroprocaine is coming back, but preservative free LA have to be given intrathecally. I hope this is very clear. Positioning. I have told you about the baricity. Done. Now with the baricity, what happens is that when we are giving a hyperbaric drug, it has a tendency to settle down. It was clear it settles with gravity. So when we are giving a drug, a spinal anesthesia, what we do is we tilt the head. This is how do we give a head down position after giving the spinal anesthesia, in order to have a higher level of dermatome which is anesthetized. I repeat, the Trendelenburg position, this is known as the Trendelenburg position or the head down position, generally used after giving heavy hyperbaric bupivacaine in order to achieve a higher level of dermatome. Like in C-sections, generally we need the anesthesia till T6 level. But what we give is at L2, L3 level. So we change the position of the patient to Trendelenburg position such that the drug is going to go to the higher levels also. This is the Trendelenburg position. Please remember, it is head down Trendelenburg position. I hope this is clear. This is meant to have a higher level of dermatome achieved for anesthesia. Indications. See, spinal anesthesia or regional central neuraxial blocks can be used for anything that is below umbilicus. Okay? Your lower limbs, your gynecological, your obstetrical, your urological, your perineal surgeries, and for analgesia purpose also, these blocks can be given. Like for lower back pain also generally, epidural block is given. Contraindications, which is outmost important. See, when we talk about indication these days, I'm sure you all must be working in very high and very good institutes. So these days they are very, the spinal anesthesia is being used for almost every case. For example, even if you have cholecystectomy, people are doing it under spinal anesthesia. If you have mastectomy also, people are doing it under segmental thoracic spinal anesthesia these days. So please don't get confused with the fact that the indications for the spinal anesthesia are only confined to your below umbilicus surgeries. Vastly it is below umbilical surgeries, but yes, if a doubt that why people are giving it even above umbilicus, yes, these days it is used, but with caution. Okay, now the most important comes about the contraindications of spinal anesthesia. When we talk about contraindication, it is always said that when you are doing a procedure, it is very important to every one of you to know where not to do the procedure, because that is the harm you are going to do to the patient. So we have absolute contraindications, we have relative contraindications. When we talk about the absolute contraindication, this is asked a majorly times, a majority of time this has been asked. We have the refusal, no consent, absolutely no spinal anesthesia has to be given. Raised ICP, if ICP is raised, if you birch the dura, there are chances of brain herniation. Local site infection, patient is in severe hypovolemia, septic shock, which is not decompensated now. Okay, coagulopathy, massive coagulopathy the patient has, like platelets are less than 50,000. You cannot give spinal anesthesia in those cases. Severe AS and severe MS, in which you have a fixed cardiac output, and if you decrease the venous return to the patient, which I'll tell you how it is decreased, it can be very, very hazardous, or it can deteriorate the patient's condition. In those conditions, we do not give spinal anesthesia. Refusal, ICP is raised, localized skin infection is there, the patient is severely hypovolemic, coagulopathy, platelets less than 50,000, completely contraindicated, and severe fixed cardiac output disorders like AS and MS. Then you have relative contraindications, systemic sepsis, some pre-existing neurological deficit is there, patient is not cooperative. We have spinal deformities like kyphosis or scoliosis, but these days ultrasound can be used to give spinal anesthesia. And you have a mild to moderate stenotic valvular heart lesions. It is relative contraindication, and you can give spinal anesthesia or graded epidural anesthesia cautiously in these patients. Nerve block, I've already told you, sensory, motor, and autonomic nerves are blocked. One important thing is this. I hope you all have already done this in your physiology classes. When we talk about sympathetic, it is thoracolumbar. Your thoracolumbar nerves are sympathetic. Craniosacral gives us parasympathetic supply of the body. I repeat, thoracolumbar gives sympathetic, whereas the craniosacral are parasympathetic. This is again extremely important, asked a lot many times. Factors affecting the spread of the drug. Baricity, I've already told you. Hyper, hypo, iso along the gravity. No problems with the gravity and against the gravity. Position, the Trendelenburg position that we were talking about. The dose of the drug, how much drug dose are you using, especially in epidural. The age, elderly people, what is the problem is you have to decrease the dose of the drug that has to be used because of the contraction of the CSF volume, and thus there is more careful spread of the drug. That is why the dose of the drug has to be reduced in elderly people. Then pregnancy. As you can imagine, in pregnancy as well as in obesity also, we have increased intra-abdominal pressures. There we have because of the gravid uterus, and there you can have because of the um, fat, the adipose tissue that is present. So in pregnancy, because of the gravid uterus, plus there is one more reason, that is the progesterone that increases the sensitivity to the local anesthetics, and thus the dose has to be reduced to around 30 to 40%. And because we have a very high chances that because of the gravid uterus, the IAP which is increased, your epidural, the epidural space or the venous plexus, your subarachnoid space, they all are compressed, and because of that compression you have more Keflet spread of the drug. When you do the Trendelenburg position, there is faster spread of the drug, and thus the dose of the LA has to be decreased to 30 to 40%. The reason is the uterus, the gravid uterus, and the increased sensitivity to the local anesthetic because of the progesterone. Spine curvature. Kyphosis and lordosis can lead to problems when we are giving the spinal anesthesia, and the effect can also vary. Okay, the drug volume, how much volume of the drug you are giving, 5, 10, 2, 3. The spread matters. Intra-abdominal pressure, obesity, I've already told you, or ascites. Patient height, less important factor, but still, more the height of the patient, lesser would be the spread of the drug. That is why we have to be very careful if the case come like that of a dwarf, okay, of some or a person who is of very short height. In those cases, we have to decrease the dose of your local anesthetic. Needle direction, in which direction is your needle directed towards, also is important, affecting the spread of the drug. For example, sometimes I've told you of a space known as the subdural space. What happens is sometimes the bevel of your needle is half in the subdural and half it has pierced your arachnoid meter. In those cases, because of the non-uniform spread of the drug in the CSF, you have a partial effect of the spinal anesthesia. So the position of the needle becomes very, very important. Now, three factors which do not affect the drug is important: gender, barbotage. Barbotage is, if you have seen in the OTs, what we do is when we are giving the spinal anesthesia, we check the flow of the CSF which is coming back. Okay, when we are checking the flow of the CSF, it does not matter, it is not going to affect. Sometimes people say that yes, we are mixing it, that is why it will get mixed with the CSF and we'll have a better anesthesia result, but it's nothing like that. Gender, the speed at which you are giving the injection, and this barbotage, mixing of the CSF with the local anesthetic, is not going to affect the spread of the drug. I hope all these factors are clear to you all. When we talk about the epidural, I've already told you epidural can be given at all the levels. It is between the ligamentum flavum and your dura mater. You can even insert a catheter. That is why epidural becomes extremely important for post-op analgesia or for the prolongation of the surgery. It leads to no PDPH, and hemodynamics perturbations are very less when we talk about epidurals. Disadvantages, of course, it's technically a little difficult, and I told you the sacral sparing is there, so blocky, patchy effect is there. The effect of epidural is not very dense like the spinal, because spinal acts directly on the spinal nerve roots because the drug is given in the CSF. In epidural, slowly and steadily it is going to go towards the nerve roots. The major complication of epidural is your total spinal anesthesia. If I'll come to the case scenario of this, if by any chance the 15 ml of the drug is deposited in the subarachnoid space because of the dislodgement or the misplacement of the catheter, this can lead to total spinal anesthesia. I hope this is clear. When we talk about epidural space, it's a negative space. Image-based question can come upon the Toohey's needle. This is the Toohey needle. Toohey needle. Other needles which can be used are Crawford or Weiss. Toohey needle has a curved tip which is known as the Huber tip, through which the catheter is going to pass. This is the Toohey needle. It has markings, 1 centimeter marking, and this is the starting, the 3 centimeter marking. It has wings which is used to hold the needle properly, and this is your needle. This is your loss of resistance syringe. I told you epidural is a negative space, so the identification of the epidural space is done by the loss of resistance. Epidural set has a catheter, and this is a filter also which is present in order to prevent the bacteria or the dust from entering the epidural canal. The techniques which are used to locate the epidural spaces are asked. One is the loss of resistance syringe, we already told you. Other is the hanging drop method, that this is the needle, this is the drop which is hanging. Whenever the vacuum comes, this will get sucked in. This is also known as uterus sign. This is asked, hanging drop method or the uterus sign. Then you can have Macintosh extradural space indicator. These are certain equipments which are actually used to identify that space. Then you can have your ultrasound, and some people also use equipment which is the balloon attached to it. You fill the air in the balloon and attach to the epidural needle, and when the vacuum will come, it will suck all the air out of that balloon. So this is how you're going to identify the epidural space. Caudal anesthesia. It is a type of pediatric epidural anesthesia. I repeat, it is a type of pediatric epidural anesthesia generally preferred in less than 6 years of age, because this is given at the S5 level. Where it is given actually is, this is an equilateral triangle which is formed by your posterior superior iliac spine at the level of S2. This is PSIS. This is again a PSIS, and it forms an equilateral triangle. The tip of the equilateral triangle is going to lie at the sacral hiatus at the level of S5. Okay, and this sacral hiatus is the place where the drug is deposited. You are going to introduce your needle here and pierce a membrane known as the sacrococcygeal membrane, and then after piercing this membrane, you are going to have the epidural space. The loss of the resistance will come and the drug is deposited. So the membrane that is pierced in caudal anesthesia is your sacrococcygeal membrane. Okay, this comes as a question, which membrane is pierced in caudal anesthesia. And when we talk about the drug, it is generally Armitage formula which is preferred. I'm sorry, I just forgot to tell you that it is only given in less than 6 years of age, because after that, this all becomes fibrous. Okay, and this all become fibrous, and this unfused S5 segment gets fused together because of that fibrous tissue. So it is less preferred in adults. It does not mean it cannot be given in adults. These days, ultrasound guided caudal anesthesia is being given in adults also, but preferred is always pediatric cases, and it is an epidural anesthesia. Done. Armitage formula is followed when we are calculating the dose of the caudal anesthesia. See, lower, if we want the block only till the lower limbs, it is 0.5 ml per kg. If we want the block on the lower abdomen, it is 0.75 ml per kg. And if it is like till the thorax we want it, then 1 to 1.5 ml kg. This is the Armitage formula. Done. And the concentration will depend upon what kind of block you need. If you are using pure, it means you need anesthesia. And if you are decreasing the concentration to half, it means you need only analgesia. This is the saddle anesthesia I've already told you about. Saddle anesthesia is only for the perineal surgery. It's going to block S2 to S5 levels. Saddle anesthesia becomes very important because certain cases come in the exam. For example, a patient who had a history of coronary artery disease has been posted for hemorrhoidectomy. A patient with coronary artery disease has been posted for hemorrhoidectomy. So what would be the anesthesia of choice? In that case, it is saddle anesthesia, because there are no hemodynamic changes after saddle anesthesia in the patient who is a high risk case. Is that clear? Saddle anesthesia is preferred for perineal surgeries, and yes, it is much preferred in patients who have certain systemic comorbidities, and this is how the question is framed. Now coming over to the systemic effects of the spinal and the epidural anesthesia. When we talk about the central nervous system, I already told you about the autonomic transmissions, 2-segment higher, motor 2-segment lower than the sensory. The most common questions asked, most common cranial nerve involved is sixth cranial nerve. We'll talk about the high spinal and the total spinal. So the most common cranial nerve involved because of the hypotension that is induced by spinal is your sixth cranial nerve. And the cranial nerves which are not affected are 1, 9, 10. That are your vagus. This is your vagus. 1, 9, 10. If you see very carefully, vagus is not affected. That is, sympathetic block occurs, but parasympathetic block is a bit preserved. Please be very careful. Parasympathetic block is preserved to an extent, whereas there is complete sympathetic blockade. Done? Now, this is why it becomes very important. When we talk about the cardiovascular system, the most common complication of spinal anesthesia is hypotension. Please be very careful. This is the most common. PDPH is not the most common complication of spinal anesthesia. The most common complication of spinal anesthesia is hypotension. And why this hypotension occurs? I've already told you we have a sympathetic block, and every blood vessel has a vasomotor supply along with it, and that sympathetic supply gets blocked, because of which you have vasodilation. And when the vasodilation occurs, we have venous pooling of the blood, and thus the venous return to the cardiac decreases, and eventually you have hypotension. One reason. Second, the systemic vascular resistance is decreased. This is the another reason for hypotension. You have sympathectomy, thoracolumbar sympathectomy, venous pooling. Yes, a bit of compensation can be done at the because of the vasoconstriction above the level of the block, and there can be sympathetic stimulation of the heart leading to tachycardia. That is your baroreceptor reflex. We'll come to that also. But the most common complication, hypotension. Why? Sympathetic block leading to venous pooling, decrease in venous return, decrease in cardiac output, plus your systemic vascular resistance is decreased. How can you prevent it? Prevention is fluid. Give preloading and co-loading the fluid, the patient, with crystalloids or colloids, at least 10 ml per kg, 30 minutes before and during spinal anesthesia. Is that clear? Loading is the one of the most important parts of prevention of hypotension in spinal anesthesia. In pregnant patients, you can have a left uterine tilt also. If hypotension occurs, then what to do? First is IV fluids. Second, drugs. What drugs have to be used? If you have a non-pregnant female, generally what we have, I mean to say non-pregnant anyone, generally we use is ephedrine or mifentermine. Ephedrine and mifentermine are used, whereas in pregnancy we generally use phenylephrine, which is a direct alpha agonist. The importance of phenylephrine is it is the drug of choice for emergency C-sections, whereas in other cases we use ephedrine and mifentermines. These are indirect acting. Phenylephrine is a direct acting, and the importance of phenylephrine is, first, it does not lead to increase in heart rate. It leads to bradycardia. Second is it does not cause fetal acidosis. That is why it is preferred in C-sections. Done. One of the most important symptoms that the patient is going to tell of hypotension is nausea, vomiting. Please be very careful. If you get a chance to attend to a spinal case, do ask the patient or do observe that if there is hypotension, the patient is always going to complain of nausea and vomiting. Okay, this is hypotension. Second is bradycardia. Again, this is because of the sympathetic block of your cardio-acceleratory fibers, that are your T1 to T4 fibers, which you remember were compensating for your hypotension. But by chance, if your spinal drugs reaches that level also, then your cardio-acceleratory fibers get blocked and you have bradycardia. The treatment of choice is atropine. Your baroreceptor reflexes. Just a quick recapitulation of your cardiac reflexes. The two reflexes which are important for your spinal anesthesia are your baroreceptor reflex and your Bain bridge reflex, which are protective reflexes for you. Baroreceptor reflex, what happens is your baroreceptors are present in the carotid sinus and aortic arch. They are stretch receptors. So what happens? We have a decrease in arterial blood pressure. Those mechanoreceptors or the stretch receptors are going to sense that decrease, and when they sense that decrease, they are going to lead to increase in the sympathetic nervous system and decrease in the parasympathetic nervous system activity. But for that, of course, for baroreceptor reflex to be active, your cardio-acceleratory fibers have to be preserved. Okay, the T1 to T4 have to be preserved. When they're preserved, it can lead to sympathetic stimulation leading to tachycardia, which can help in maintaining your blood volume or the cardiac output. I hope I'm clear. Second is the Bain bridge reflex. What happens in Bain bridge reflexes? We have venous pooling of blood after spinal anesthesia. This venous pooling leads to decrease in the stimulation of your atrium. That is, you have less amount of blood that is coming. If lesser amount of blood is coming, then what happens is we have a decrease in the activity of sympathetic, and thus we have bradycardia. We have decrease in the sympathetic activity because less fluid is coming. Now what happens is, if we are giving IV fluids, when we load the patient with IV fluids, then these receptors, they sense that yes, now fluid is coming. So now they start pumping more. As soon as the volume, the venous return increases, your atria, they sense that yes, now the fluid is coming and now it is going to pump more. This is Bain bridge. This is a protective reflex that when there is lesser volume which is present in the atria, at that point we should have bradycardia because there is less volume, less blood, and thus less pumping has to be done. Now, how these two balance each other? Now, how are they going to balance this? In cases of hypovolemia, when you have hypovolemia, baroreceptor reflex is more activated than Bain bridge reflex. Thus we have tachycardia. But when you have hypervolemia, then Bain bridge reflex is more active. Thus, more fluid, more heart rate. That is your hypervolemia. You have Bain bridge reflex that dominates. Because eventually, last, intravenous infusion is there. Right atrial pressure increases. The right atrial receptors stimulate. Your Bain bridge reflex say pump the blood more. So let's increase the heart rate. Whereas what happens in the baroreceptor reflexes, it is different. In baroreceptor reflexes, what happens as soon as the cardiac output increases, your stretch receptors in the carotid and aortic arch will say, oh, there is so much blood now. Let's decrease the heart rate and let's stabilize the heart because already the cardiac output is a lot. This is how Bain bridge and baroreceptor reflex balance is going to maintain your cardiovascular system. I repeat, when it is hypovolemia, baroreceptor reflex predominates. When it is hypervolemia, Bain bridge reflex predominates, and thus maintaining the homeostasis of our body and compensating for the loss. I know we have a wonderful body that God made. Coming to high spinal and total spinal, a lot of time these questions have been asked. What is high spinal? What is total spinal? And different case scenarios are given for this. When we talk about high spinal is the cardio-acceleratory fibers T1 to T4. They are blocked in high spinal. It could be because of the excessive dose or because of the Trendelenburg position, the 20-degree tilt that we give. That is high spinal. When we talk about total spinal is the involvement of your brain stem. You have hypoperfusion of the midbrain. Your cranial nerves get involved. That is the total spinal. You have hypotension, bradycardia. Along with this, those two are also present in high spinal also. But in total spinal, you have your respiratory depression along with the involvement of your cranial nerves. Brain stem gets involved. That is total spinal. The patient becomes unconscious, respiratory depression. You have aphonia that is present. You'll always observe that after giving spinal anesthesia, we always ask the name of the patient to check whether aphonia is there or not, right? This is how the cases of the high spinal and total spinal also come. Like in total spinal, the case scenario will be a very big scenario which will be given, but you have to check out that key points, the key words in it. For example, a pregnant female is posted for the C-section, and pregnant female posted for labor analgesia was given epidural, catheter was inserted, everything was uneventful. But after the 15 ml of the drug in the epidural catheter was given, suddenly the patient became unconscious. She had loss of respiratory depression. She became hypotensive. There was bradycardia. What could be the reason? The reason could be that 15 ml of the drug has gone into the spinal canal, that is the spinal cord, and thus it has, after it has gone into the subarachnoid space, it has led to total spinal. This is how the case for the total spinal comes, that a large volume of drug inadvertently has entered your subarachnoid space, and all these symptoms which are like last doom symptoms, hypotensive, bradycardia, loss of consciousness, respiratory depression has come. That is your total spinal. Talking about the respiratory system, not much changes come in respiratory system, but when we have a high spinal, then yes, the accessory muscles, that are your intercostals and your abdominals, they get blocked, and at that time the respiration can be compromised, especially in patients of COPD. The pulmonary complications only come when the level of the block is like till the cervical nerve, C3, C4, C5, that are the phrenic nerves, which are the phrenic nerve gets involved, and that is generally in the cases of total spinal when the pulmonary complication occurs. In normal, there is no pulmonary complications, and in respiratory dysfunction, we generally prefer giving regional anesthesia until unless we are very cautious about the level of the anesthesia that we have to maintain. GIT, sympathectomy is there, only parasympathetic dominance. So we have peristalsis that is increased. We have small contracted gut. Urine. When we talk about the urinary bladder, we have autonomic denervation. Both sympathetic, parasympathetic supply goes. We have a atonic bladder. This is the post-operative most common complication, no voiding reflexes and retention of the urine. That is why generally we prefer to catheterize such a patient, because we have urinary retention. Then we have metabolic endocrine stress response that is inhibited. It is per se, it is advantageous because every surgery has a stress response associated with it, which is decreased by your regional anesthesia, because our regional anesthesia is going to decrease the level of your bradykinins, your prostaglandins, and all your inflammatory markers in your body. So please remember, metabolic stress response is decreased, which is advantageous for us. Coming to the same thing, T1, T4 cardioaxillary fibers, if it reaches to C3, C8, then the patient is going to complain of tingling or anesthetizing of the upper limbs also. You can have respiratory arrest, the accessory muscles of respiration he won't be able to use. If you have intracranial spread, hypoperfusion of the brain stem is also there. Of course, you have loss of consciousness, you have respiratory arrest. So these are the case scenario that comes, and you have to identify at what level the anesthesia drug is actually acting at. In total spinal, I again repeat, It will like a doom case. Everything is gone. Hypotension, bradycardia, respiratory arrest, loss of consciousness. That is total spinal. Done? Then you can have last, the systemic toxicity. We have already talked about this in a local anesthetic class, in which because of the introduction of the local anesthetic into the vasculature, we can have last. In that, the very first symptom that comes is your CNS symptom. Just remember this. If the case has CNS system over the CVS, it is last, systemic toxicity. It will very clearly state that local anesthetic was given and you have circumoral numbness which is present, and neurologically patient gets dizzy, we have sedation, and we have seizure activity in the patient. That is your last. The treatment of choice is resuscitation. If arrhythmias occurs, then amiodarone. And lastly, you have 20% intralipid emulsion, which creates a local anesthetic sink theory. It creates a sink, and your local anesthetic goes via renal circulation out of your body. That is your last. I again repeat, the case that comes in last will clearly state about the neurological symptoms coming, that are your circumoral numbness, your dizziness, and seizure activity. Done? Vasovagal syncope. See, the case of vasovagal syncope, it does come, and this is like while you are giving the spinal anesthesia, or you have taken a lot of time while giving the spinal anesthesia. At that time, the patient felt aphonic, or patient lost consciousness, or patient became bradycardic. That is the vasovagal syncope. The local anesthetic has not yet entered the body. It is only during the procedure that the patient started feeling dizzy. That is your vasovagal syncope. And as soon as the patient, whenever he or she experiences this, you have to just maintain the supine position back, and the patient is going to get normal without any active intervention within minutes. Okay, this is not going to happen the high spinal, total spinal, or the last. The patient is not going to come back normally on its own. Whereas vasovagal syncope, the case would be anesthesia practitioner was just giving or introducing the spinal needle, and the patient started feeling aphonic or dizzy. That is vasovagal syncope. Infections, meningitis, encephalitis, because of the skin commensals, because of which aseptic conditions are very, very important while giving regional anesthesia. Please see the microorganisms which are responsible for them are spinal. We have Streptococcus viridans. You have to remember this. Spinal, we have Streptococcus viridans, and epidural is generally your Staphylococcus epidermidis. I repeat again, in spinal, Streptococcus viridans. Epidural, the most common that had been found is Staphylococcus epidermidis. This is your skin commensal, right? Then epidural and spinal hematomas can be formed specifically in those patients we had platelet dysfunctions or coagulopathy patients, in which you can have a mass effect because of the hematoma, and hematoma has to be drained after that. And because this hematoma can lead to nervous ischemia because of that mass effect. Then you can have inadequate or patchy effects. These are because of the subdural placement. I talked to you about that space which is present, in which we can have in which we can see CSF, but not the free flow of CSF is there. So there is incomplete mixing of the drug with the CSF. The dose that you have given is not right. Needle has moved, or your drugs has lost its potency. Backache. One of the most important complaints of the patient is the backache after spinal anesthesia. This is generally because of the dura cutting needles. We have a localized inflammation, and we have reflex muscle spasm which can lead to backache, but nothing to worry about. Your normal NSAIDs can relieve that backache, and it is self-limiting in nature. Quadra equina syndrome, generally it was seen when we were using lignocaine. This is a neurotoxic syndrome, generally with lignocaine, when you had intraspinal catheters that are being used, but nowadays it is rarely seen. Most important, post-dural puncture headache. Again, a lot of questions are asked on post-dural puncture headache. See, as the name suggests, what happens is we have the leak of CSF. We have a persistent leak of CSF. Because of that leak, the formation is slower than what is leaking out, and there is a traction on the meninges, or we have a traction which is present. Because of that traction, we have a stretch of the intracranial contents, and we have the activation of the adenosine receptors which are present. Because of that stretch or activation of the adenosine receptors, we can have vasodilation of the intracranial vessels, and stretching of the meninges is present. This leads to the traction on your pile nerve fibers and eventually leading to post-dural puncture headache. I repeat the mechanism. We have the leak of CSF because of the breach in the durameter. The leak of the CSF leads to decrease in the CSF volume and pressure. We have the intracranial content that is shifted. Adenosine receptors are activated. We have the stretching of the meninges, plus because of the adenosine receptors that were activated, we have vasodilation of the intracranial vessels, and everything is leading to traction, and we have pain. What kind of pain? It's a throbbing pain in frontal, occipital, retroorbital area, which can start anywhere like 12 to 72 hours, and it can persist till 2 weeks also. The characteristic finding in this pain is, which is differentiating it from the migraine, is it gets relieved when we lie down, and it gets exaggerated in the supine and the sitting position. I repeat, it gets relieved when we lie down and exaggerated as soon as the sitting position is there. We have photophobia, nausea, vomiting also. Predisposing factors are your dura cutting needle. If you are using a smaller gauge needle, multiple attempts, females, young people, and pregnant females specifically, and your needle bevel. If the orientation of the needle bevel is along the axis of the spine, then it is preferable, or if it is against it or perpendicular, then there is more dura that is damaged. Okay, these are the predisposing factor. Treatment of choice remains fluid and NSAIDs. Analgesics and fluids are the treatment of choice. The second treatment of choice will be your caffeine, supine position, and stool softeners and sumatriptan, which are given. The definitive management of such a patient is epidural blood patch, which is like 15 to 20 ml of epidural blood patch is given. How it is given is, under all aseptic conditions, what we do is we withdraw the blood of the patient, and simultaneously we introduce that blood into the epidural space, one space below or at the same level where we had given the epidural, where we had given the spinal, and it is seen that generally this coagulates, and this is now going to close that breach in this durameter. That is why this epidural blood patch is given. Other than that, there are two more blocks which are being used these days to decrease the pain. That is your sphenopalatine block, lesser occipital, or the greater occipital block. These are the blocks which are used to decrease the pain. Sphenopalatine, lesser occipital, and greater occipital block. I hope this is clear. PDPH. Certain additives are added to your spinal anesthesia drugs in order to fasten the duration of action, prolong the duration of action, and also to decrease the systemic side effects. We have done this in our LA classes. But the questions that were asked are, like, for example, if opioid is added intrathecally, so the most common complication after the addition of opioid is pruritus. It is pruritus, which is because of the action of the opioid receptor, the centrally acting opioid receptors. These opioids act on that are present in your substantia gelatinosa, and the treatment is asked for this pruritus actually. These are your antihistaminic and your naloxone. Both can be used, and they both can be used without doing any effect on its mean action of analgesia. Naloxone does not decrease the analgesic action of your opioids. Okay, it is an antidote, but the analgesic effect is maintained. So pruritus is the most common complication of intrathecally introduced opioid. You can add clonidine, dexmedetomidine, that are your centrally acting alpha-2 agonist. You can add neostigmine, epinephrine. Epinephrine is a vasoconstrictor. It will help the local anesthetic to stay where it is. It will decrease the systemic absorption and thus prolong the effect of your local anesthetic drug. Then sodium bicarbonate is also added. If you remember, the pH of local anesthetic matters a lot when it is to function. So soda bicarb helps in giving us more non-ionized form of local anesthetic, which can act on your nerve fibers better. Now there are certain cases, this is the last part of my discussion. Yeah, this is the last part of my discussion, which are most of these cases I've already discussed to you before. See, the cases that comes are like, for example, a 75-year-old which is posted for periampullary carcinoma surgery was given epidural morphine or epidural opioid for analgesia. The answer is asked, why was it given epidural opioid? The question is that the epidural opioid have no autonomic consequences, hemodynamic alterations are not present, and it spares the motor fibers also. It is only the pain that goes because of the acting of these opioids in their central opioid receptors in substantia gelatinosa. They spare the motor fibers and no hemodynamic changes are there. That is why epidural or intrathecal opioids are preferred. Done? Second, patient for C-section, given spinal anesthesia, Trendelenburg position. Suddenly, the patient complains of nausea, tingling sensation of the upper limbs, hypotension, bradycardia, and aphonia. Total spinal. Done? This case also comes like, for example, if the patient is posted for labor analgesia, epidural catheter was inserted, 10 ml of drug was given, followed by the same symptoms. Even that is total spinal anesthesia. Done. In this, the key point is the Trendelenburg position. After giving hyperbaric bupivacaine, if you place the patient, especially a pregnant female, in Trendelenburg position, there are very high chances that the spinal drug will go cephaloid. Done. Vasovagal syncope, it is during the insertion. You have not given the drug yet. The case will clearly state that the anesthesia practitioner was giving the spinal anesthesia, and during the procedure itself, the patient started feeling aphonic and loss of consciousness was there. That is vasovagal syncope. Last, inadvertent introduction of the local anesthetic into your blood vasculature. That is, your CNS symptoms will be there. Circumoral numbness would be there. Seizures, dizziness would be there, clearly stating in the question. I already talked to you about this. Epidural anesthesia, gave 15 ml. Within 3 minutes, hypotension, everything doom that was going to come has already come. Anesthetists were giving spinal, and during that it came vasovagal. Labor analgesia. One thing about labor analgesia I want to talk to you about is, see, labor analgesia and post-op analgesia. For both of them, epidural is the drug of choice. And the beauty of epidural is that by decreasing the concentration of the epidural, you can have motor block sparing. Okay, you can have the differential block that I talked to you about, that A alpha fibers are least sensitive, right? So decrease the concentration and you can spare your motor fibers. That is what is known as the walking epidural in labor analgesia. You use only 0.0625% of the drug and the patient is able to walk with assistance during labor analgesia also. And that is same with post-op analgesia, in which these days we want the patient to get mobilized fast, right? Mobilization really helps the patient and the pain also has to be decreased. So 0.0625% drug is given and we can decrease the pain of the patient, along with patient can walk. Then the case comes that the pregnant female is there who has a moderate MS. Moderate MS, regional blocks can be given. Spinal anesthesia or epidural anesthesia graded can be used. But in severe cases or in cases of Issin-Mengar syndrome, we have to avoid, or any other obstetric condition in which it is like GA, it has to be preferred, like massive hemorrhage is there or hypovolemia is there. In those cases, even in pregnancy, we prefer general anesthesia. But as such, in C-sections, regional anesthesia, spinal anesthesia is the choice of anesthesia. Saddle, I've already talked to you. Choice of anesthesia for TERP syndrome is asked. It is spinal anesthesia because it helps us in knowing about the symptoms of the TERP syndrome because of the hyponatremia, all that loss of consciousness or the CNS symptoms that comes. It helps. The spinal anesthesia, if the patient is conscious, he's able to tell you about it. Okay. Choice of anesthesia in LACS is regional anesthesia until and unless we have contraindication to regional anesthesia. Then paracervical block. It is given in questions, but paracervical block is only for labor analgesia. It is not meant for C-sections. It is only for post-op analgesia you can use, or for labor analgesia. You can use paracervical block. That too only in the second stage of labor. Done. Labor analgesia, the only important thing is that first stage, we need an effect till T10 to L1. Second stage, it is only the sacral plexus because already the descent of the head has started. So the majority of the pain is S2 to S4. And labor analgesia can prolong the second stage of labor. This labor analgesia question has been asked once or twice, that which is the dermatome level for the first stage. It is T10 to L1. Second stage S2 to S4, and it leads to prolongation of the second stage of the labor. Choice of labor analgesia is continuous lumbar epidural. I repeat, the choice of anesthesia for labor analgesia is continuous lumbar anesthesia. Done. The very last slide, that are the dermatome levels which are required for common surgeries. Upper abdominal, you have to have an effect till T4, TERP T10, hip surgery T10, foot and ankle L2, hemorrhoids S2 to S3. Along with this, please always remember that your inguinal ligament is a landmark for T12, umbilicus for T10, and your xiphoid is for T8. Your nipple breast is for T4, or your sternal notch. So please remember these landmarks for deciding the dermatomal levels which are required for common surgeries. I hope regional anesthesia or the central neuraxial block are clear. Kindly repeat them again and again because they form a bulk of questions that are going to come in the NEET-PG. Thank you.